Hello, is this working? I will be speaking today in English so that Christine can follow my introduction rather than Swedish. So, my name is Madhuri Gogineni, and I am honored to be here and sad that Marie cannot be here today, but it is really because of her that we're having this day and also the topic which is dear to my heart and a reason that Marie and I got to know one another over the last years that I've been living and practicing in Sweden. So, who am I? Well, I am Christine Mitchell's warm act, but I'm also an American physician, and I've been practicing medicine here in Sweden since 2012. Um, I am an internist by training and practiced in the US for 15 years before moving to Sweden 8 years ago. I worked in the internal uh, acute kliniken, so the emergency department at Karolinska Solna for 5 years, and now in palliative care at Stockholms sjukhem in Stockholm. And during these 22 years, I have practiced across a very broad range of settings, including public and private systems, urban and rural, wealthy, underserved, intensive and palliative care, as well as across a remarkably diverse group of both patients and colleagues. And I've had the privilege of being able to see how different landscapes of healthcare can present both unique and common ethical challenges. The common thread throughout all of these settings, in my experience, has been the strong desire among all healthcare workers to provide good and ethical care to their patients, to try to understand one another's values, bridge the differences, and help their patients. When things tend to come in the way of this is when we tend to see ethical dilemmas. So I thought I would just begin briefly by distinguishing the ethical dilemma from moral distress. It's often a bit fuzzy when we talk about it on the wards, because an ethical dilemma is when there are multiple ethically justifiable courses of action, and it's unclear to the practitioner which course they should take. While moral distress, which we hear quite a lot about in today's debate, has to do with feeling that you know the correct course of action but are unable to implement it. It's characterized by powerlessness and can have internal and external causes. Internal causes, such as a reluctance to take a difficult decision, and external, which have to do with organizational infrastructure and resources. So often, both ethical dilemmas and moral distress tend to occur when there is a disconnect between theory and practice, between expectations and reality. So, Christine, your topic could not be more spot on, even here in Sweden. Um, when I speak to my colleagues, nurses, doctors, social workers, physical therapists, everyone who works in a clinical setting, they often tend to informally refer to these types of situations as either avoidable or unavoidable. It might be an oversimplification, but if I had to describe the difference, it seems to me that the avoidable problems are ones that healthcare workers feel could be addressed by the powers that be. Whereas the unavoidable problems that we come across in our ethical or challenge to provide ethical care has to do more with the things that are inherent to meeting other human beings, whether they be patients or other professionals. So I thought I would just very briefly talk about a couple of areas that have led to ethical dilemmas that occur rather frequently in my experience over these 8 years, regardless of acute care settings or the palliative care setting, and that is the transcultural conflicts which result in ethical dilemmas. Sweden is becoming ever more diverse, just as we've seen in the US for quite a long time, and it is challenging for staff and personnel to stay true to their ethical principles and ethical codes while being able to respect the differing values of their patients and at the same time not succumbing to moral relativism. This is a constant balance that is very hard to navigate unless one has rather rigorous training in how to navigate these issues. There's another area which has come up, and we've seen it in consultations at the Karolinska Hospital Ethics Committee, which have to do with ethical dilemmas that arise in the absence of legal or policy guidelines. This is a very interesting difference between Sweden and the US in my experience, where in the US, many issues are legislated very clearly, and I was surprised and have expressed on several occasions that there isn't always that same amount of formal legal guidance on how to handle certain areas of medicine in Sweden. It results in a tremendous amount of flexibility, which I think is positive in being able to take care of the individual patient, but it can be an immense burden and responsibility for an individual clinician to make a decision and have to stand for that without a policy or guideline behind them. An example of this is, as we see often in both the acute and palliative care settings, are adult patients who have impaired ability to make medical decisions. It's not necessarily legislated as to how one should handle these situations. And as my last point states, it does require a tremendous amount of ethical judgment to be able to handle these well. So I'd like to come to the real focus of my talk today, which is really about it's what I hear the most about on a day-to-day basis, what I read about in the newspaper. I'm certainly not alone in this, and we see it at the ethics committee at Karolinska as well when we receive consultations, that the constant shortage of resources can create tremendous amount of moral distress and compromises in patient care. I just would like to say, though, that this is I see this as an absolutely necessary challenge in what is otherwise a fundamentally ethically justified medical system. The Swedish system strives to provide medical care to all members of its society. So inherently, this is an ethical system. And as someone who has worked in both the United States and here, I can say that my overall sense of moral distress is much lower here than it ever was in the US, just given the outer structure of the Swedish medical system. But having said that, within our system, our healthcare workers do experience this sort of moral distress. They feel that they're required to provide ever increasing standards of care without corresponding resources to do it. So let's see, there we are. Yes, this slide tries to illustrate this sort of vicious cycle that can be triggered with limited resources. As everyone knows, when you have fewer beds, fewer staff, and less time for ethical patient care, personnel experience stress. This tends to land on the shoulders of nurses, often the heaviest, and particularly nurses working in critical care settings. Over time, when one is unable to affect change, this leads to a sense of powerlessness, which defines moral distress. Moral distress can then lead to burnout, which can manifest in different ways. One is a cynicism, which of course affects the quality of patient interactions and patient care. And the other is the unfortunate turnover that we are seeing in Swedish healthcare today. There are multiple reasons for this turnover. I by no means think that this is the only reason, but the turnover does in turn have its negative consequences. As all of us who've worked within healthcare know, a good team communication and core group is essential to delivering excellent healthcare to patients and to maintain ethical standards. What tends to suffer with turnover are these relationships. As a result, we see less communication within the medical teams, which then trickles down to how much we talk to our patients. This in turn leads to unclear goals of care, inappropriate treatments, which are often result of the team not having taken the decision as to what direction to go with a patient. This requires a constant group of people that have goals daily, weekly, and in some patients' cases, monthly. All of this in turn leads to greater work stress, and the cycle continues. So this seems incredibly distressing and pessimistic, but the good news is that we can actually do quite a bit to alleviate the moral distress and the ethical dilemmas and help our personnel cope with these things. Ethics education and ethical structures help a great deal, that even when you cannot change the circumstances of a otherwise difficult clinical situation, you can alleviate the moral distress that can come from it. This is specifically shown with nurses, where turnover is actually reduced when some of these programs are put into place. The interesting thing about Sweden is that, again, ethics work and ethics structure is not centrally mandated, and therefore we see a huge variation across the country. It was incredibly interesting to be at the annual meeting for the National Ethics Network a few weeks ago, where we had representatives from all over Sweden, and there is one particular region, Norrbotten, which is all the way up in Sweden, which has a fantastic structure. They have immense governmental regional support, which has allowed them to finance education for their local ethics representatives in both the outpatient and inpatient settings. And it's resulted in a very, I would say, a very healthy ethical climate for the healthcare personnel there. If we look at Stockholm, we have several hospitals, and we have Karolinska Hospital, which in great part due to Marie Chenique's efforts over the decades, has had an ethics committee at the hospital since 1994 and a very well developed ethics structure. While we have other hospitals in the very same city that have no formal ethics structure whatsoever. So there is a lot to do, and a lot of work can be done. And as I always say, that there is no perfect system, but in my experience, I would argue that the Swedish system comes awfully close, but there's always room for improvement and inspiration. So, with that, I'd like to turn it over to Christine, and we look forward to hearing your inspiring words.